If you remember back, the pleural space is basically an area bordered by the visceral and the parietal pleura, or visceral attaches to the lungs and some of the internal structures, and the parietal attaches to the chest wall, the mediastinal space diaphragm. There's a small amount of fluid which is there. It's continuously being secreted and absorbed, and it allows for a frictionless, or reduces the friction between those two surfaces. One of the pleural diseases that can happen is where you have what is called a pleural effusion, where you have accumulation of excess fluid in intrapleural space. And because of that, the pleura do not function appropriately, and the lung then below that portion collapses. Okay? You're going to end up having some atelectasis, and depending upon the degree to which you have an effusion, you can actually have a shifting of the mediastinal structures. In doing so, you could end up having a reduction in cardiac output, and by definition, obviously, this is a restrictive lung disease. So here we have accumulation of fluid in the intrapleural space, preventing that portion of the lung to become fully inflated, and it becomes atelectatic. In the process, you have a shift away from the affected side, so that the movement of the heart and mediastinum are towards the opposite side. We detect these by a chest x-ray and confirm it with a lateral decubitus. That is the key facet to why we use it. You can also, by looking at ultrasound and CT scans, pick it up. There are two types of pleural effusions that you need to be aware of and how we distinguish between them. One is called a transudate, and one is called an exudate. Transudate basically is just a movement of the fluid out of the capillaries into the intrapleural space. And usually it's a very thin, watery, not a lot of cellular material, very little protein. If you were to look at it, it looks like almost plasma, clear and light straw colored. Protein content is very, very low. And it usually has a higher pH. When Mary went through and talked about your blood gas analyzers, right? You can run, we normally think, oh, well, we're going to run blood through there, right? Well, you can run anything through there, including gas, and get a partial pressure of a gas sample. But you can also run pleural fluid and other stuff. We'll leave it at that. This is usually because of an elevation in hydrostatic pressure or a fall in oncotic pressure that promotes the movement of fluid out of the capillary space. Guys, do you want me to go back through Starling's law of the capillary? Okay, I will. Since I'm getting all kind of looks like, what? That's why I got a blank space here. If you remember, there are 5 factors which affect movement. If this is what we're going to consider the venous side, and this is the arterial side of the capillary. I got those backwards, don't I? This is the arterial side. This is the venous side. As the blood goes through, there's a capillary hydrostatic pressure. Hydrostatic pressures always push outward. There's also an interstitial hydrostatic pressure that pushes the fluid back in. There's a capillary osmotic pressure, or oncotic pressure, same dip. Oh, drew that wrong. That pull inward, and there's an interstitial osmotic pressure that again pulls inward. So if this value is reduced, if there's not a lot of plasma proteins, not a lot of albumin, there's nothing to hold the fluid in there, it leaks out. The same would be true as if we had this elevated, and we would call this, in the case of the lung, pulmonary capillary wedge pressure. If that pressure is elevated, it's going to push fluid out also. Now what we're talking about here is not so much this being the alveolus, which is true, we're talking about just being the pleural membrane, because they're embedded with capillaries also. Okay. There is a 5th factor, and the 5th factor has to do with the leakiness
of the capillary itself, and that's one of the causes of non-cardiogenic pulmonary edema, or what we consider ARDS, is there's an alteration in that permeability of the capillary, and they leak more fluid out. So what we're talking about here with a transudate is basically a fall in osmotic pressure or an elevation in hydrostatic pressure. Either of them will lead to the same end point. Most common cause of transudates is congestive heart failure, because there's an elevation in the pulmonary capillary wedge pressure. Fluid leaks out into the interstitial space and into the lungs, and also leaks out into the pleural space. So you have an accumulation of fluid in excess of that small amount in the intrapleural space. Multiple other things dealing with other organ systems. You can see the low osmotic pressure from a low albumin. The congestive heart failure, specifically left side heart failure, is the most common cause. Exudates are different. Exudates usually are something to do with a pleural or a lymphatic problem. This is where you see a very high protein count in the pleural fluid. You'll also see a very acidic pleural fluid. Lots of cellular debris, and it's indicative of some kind of inflammatory process going on. Often these are having to do with either some kind of malignancy. Mesothelioma is a pleural cancer that can develop, but it can be, if you look, any kind of infectious process can end up having pleural effusions that become exudative in nature. You can have water, you can have water and air, you can have pus, the development of chyle. Chyle, again, is lymphatics. Lymphatics, remember, the intrapleural space is secreted into and drained by the lymphatic system. The lymphatic systems can't effectively drain because there's tumors in the lymphatic system. You're going to have a backup of a fluid there, and you can actually have chyle, which is what the lymphatic fluid is called, backing up into there. So hemothorax, again, is basically a collection of blood in the area. Could be a sign of malignant disease. More often than that, it's secondary to trauma, including iatrogenic trauma, as you would see with an open heart surgery. Okay. That drainage we typically call, because there's blood involved, serosanguinous is the term that is used to describe a drainage that is the normal serum colored, that's straw colored, but also has blood intermixed with it. An empyema or a pyothorax is basically pus in the pleural cavity, and this is usually secondary to some kind of inflammatory process. And the way we diagnose it is with the use of a thoracentesis, which is basically an insertion of a needle into the pleural space and draining the fluid off with a syringe. Chylothorax, as I mentioned, was usually associated with the thoracic duct being blocked. Chyle, if you were to look at it, is a milky white substance, so you would have that kind of a discoloration to the pleural fluid. And often that's a sign of malignancy being present. You can have a loculated pleural effusion where it's to a single area. For whatever reason, the pleural space, if we were to think of it, the pleural membrane's okay here, but here it's accumulated, where it's attached to the two pleural membranes attached to each other, so that this is a loculated effusion that occurs. And it's often in the two fissures on the right or the one on the left. How they look is that they're going to have a reduction in chest expansion. It hurts to take a deep breath, and they have dyspnea present. There is a shift of the point of maximal impulse and of the trachea, and that shift is away from the affected side. A very dull percussion note, reduction in breath sounds, and obviously they're going to be tachypneic. And again, we are considering this a restrictive disease because lung volumes themselves are reduced.
Just like every other disease we've had in the milder form, it's just a respiratory alkalosis that they exhibit. Again, because of the hypoxemia. As it gets larger and larger, you'll end up having not only a ventilatory failure, but a lactic acidosis developing secondary to the profound hypoxemia. Blunting of the costophrenic angle. This is the disease where we see the costophrenic angle not look normal. There's a loss of it. Okay, we call it a pleural meniscus sign. In this case, mediastinal shift is getting away from the affected side. The diaphragm will be non-functional at an area, and you really need to have a pretty sizable effusion before you can actually see it on an upright film, but a lateral decubitus can pick up a whole lot smaller of loss or gain in fluid. So here's a lateral decubitus, and as they're laying on their side, we can see the pleural fluid kind of lining there. How do we manage it? Well, again, the oxygen therapy protocol would be appropriate if the patient's hypoxemic, treat hypoxemia. Often a thoracentesis is used to drain if the pleural effusion is recurrent and large, chest tubes may be necessary. Pleurodesis refers to the process of putting a substance into the pleural space that's irritating and causes the two pleural membranes to want to stick together. It could be something like TELP or some other mechanisms. And obviously, if there's an infection going on, they would need some antibiotics, and that hyperinflation protocol would be the other protocol that would be primarily involved. What a thoracentesis is again an insertion of a needle into that space. We can use it for removal of a specimen to do biopsies. We can also just use it to therapeutically drain. Patients should be evaluated for blood dyscrasias are going to cause increased bleeding. Caution needs to be used when they're on anticoagulants, and they can be done under fluoroscopy so you can watch where you're inserting it into. This isn't something that we would necessarily be involved with other than observation. If you ever have a chance to see one done, it's kind of an interesting procedure. But basically, our role, if at all, would be assisting the physician in maintaining a sterile environment. And what they want to do is just remove a small amount of the pleural fluid. Actually, removing too much and removing it too rapidly can actually cause worsening of the condition, though. So it's kind of done on a small basis. How the patient's positioned, and basically they're in the spot where they're able to go ahead and insert a needle into the pleural space and drain fluid off. And again, we always want to be on top of the rib, remember, because on the bottom is where all the nerves and arteries and veins run. Lots of analysis can be done on it, including looking for anaerobic tuberculosis or fungal cultures, doing a cytology, which is basically looking at the cell types that are present to determine if there's any malignancies present. Our primary thing would probably be pH as being the primary one. Send it down to the blood gas lab to measure the pH of the sample. Thoracentesis is not without complication. You can end up collapsing the lung by going a little too far, go through the pleural space and into the lung itself and collapsing it. You can introduce subcutaneous emphysema as we showed last time. And that re-expansion pulmonary edema is what I was mentioning can happen. You can actually induce a pulmonary edema secondary removing fluid too fast. Last time we showed liver smooth. Did I talk about House of God before? The book House of God? Oh. Well, in your readings, in your spare time that you have a lot of, I know Mary's class is going like cake, so you got lots of extra time. There's a book called House of God. That was a joke, yeah. And it's written by a physician, and it's set in his first year of internship after graduating medical school. And it's tongue-in-cheek, but it's about all the goofy stuff that happens in hospitals, and he comes up with these different rules of the house of God. And it's, one of them is Gomers go to ground, meaning Gomer, which stands for get out of my emergency room. If you leave them alone, they'll find a way to fall on the ground. He talks about the bed height being ortho height or neural height. If they fall out of ortho height, they go transferred to the orthopedic wing. If they fall out of the neural height, they get transferred to the neurology wing. But there's one of the rules is there's the first thing to do with a code is take your own pulse, which actually is a very good rule. But one of the ones that has to do with this made me bring it up. There's no body cavity that cannot be reached with a 14-gauge catheter and a good strong arm. It was talking about somebody doing a liver biopsy and punctured the heart. So it was kind of went a little bit far. Oops. Yeah. House of God is the title of it. You can get it on half.com or Amazon for a couple of bucks. And we'll leave it at that. Okay, so that's pleural effusion as a function of causing respiratory distress. Other disease states are having to do with the chest wall itself and the malformation of the chest wall. Kyphoscoliosis is the more common occurrence, although you can have either scoliosis or kyphosis. Often in the case of patients that we end up encountering, it's a combination of both. Kyphosis is the anterior posterior curvature of the spine where you end up with that classic humpback or hunchback. Scoliosis is a lateral curvature. And when you have kyphoscoliosis, it's going all directions. Okay, this is a chronic disease. I mean, you're born with this, you live your life with this. Here you can see the spine, both a scoliosis and there is a kyphosis there as far as it's going back and forth. Obviously, the lung cannot adequately expand in those areas where the spine is tortuous. Hard to take a breath, frequent cases of atelectasis, inability to adequately ventilate. These patients often are ventilated at nighttime because, not invasively, because it's so difficult for them to ventilate. They also have inability, a very poor cough effort, because part of the cough mechanism is to take a deep breath. Can't take a deep breath, can't cough, and because of that they can't mobilize secretions, so they end up with frequent infections. Because of the atelectasis, they have, whichever way the lateral curvature goes is typically the way that the mediastinal shift happens. More ventilation than CPAP, more BiPAP than CPAP, as we'll find, because it's really not re-expanding. I mean, their chest is so deformed that it's not something that the atelectasis is going to be treated, quote unquote. You just got to manage it as best you can. I would say that that's a hunchback.
Who would you say that patient is?
I have no idea. But you'll see these folks just poor walking around the mall and whatnot. They're. Oh, yeah, well, that's severe. It's scoliosis is probably more common than we encounter, and a good part of 10% of the population probably has some involvement. Fortunately, a very small percentage has a deformity which is large enough to be identified. It's idiopathic in most cases. Sometimes it can be a problem with the vertebral column or the neuromuscular support that is present for the spine that end up having defects associated with that. And you'll notice right off the bat when you do an inspection that they have this alteration in their thoracic cage. They do present typical respiratory distress. It should be an increase in heart rate and blood pressure. But
poor cough, poor sputum production. Because of the chronic hypoxemia, that can be cyanotic, digitally present. And if you were to do a chest assessment, you would see a tracheal shift, that dull percussion note, and increased tactile and vocal tremulous. Chronic cases will end up having your typical lung core pulmonal picture with development of right ventricular hypertrophy and chronic polycythemia. And it is a restricted disease. Unless you're Gilbert. I told you about Gilbert before, didn't I? You know, he was a guy with real bad kyphosis who smoked three packs a day. So he had mixed disorder. His normal PO2 was somewhere between 28 and 34. He actually was into his 70s, which stunned me. Depends on the severity. I mean, and how well you manage it. I mean, he was a cat, and he had to be on his 8th or 9th life. Ask Nancy about him. She'll tell you stories too. Mild conditions tend to begin with the respiratory alkalosis picture. More often than not, especially towards end stage, there'll be chronic ventilatory failure, and that cause of hypoxemia is primarily a hypoventilation. Here you could end up seeing a huge scoliosis that is happening in the process. On chest x-ray, you'll note the thoracic deformity. Obviously, we just saw some. You'll probably see areas of atelectasis present, and if the core pulmonale is significant, you'll see an enlargement there. This one doesn't show up really well, but here's the spine. Obviously, thoracic expansion is going to be difficult when you have that. And if you look, here's the lung. And here's kind of a lung. So what you're probably going to end up having, as far as we're concerned, is some form of oxygen therapy. There are braces that they can do, especially with scoliosis in the formative years, to try and correct that process. There is electrical stimulation in mild cases that they can do, stimulate the muscles that are around the spine to try and strengthen them. And there are surgeries that can be done where Harrington rods or Luke rods are actual rods that go into the spinal column and straighten it out. And it can work to some extent. Probably these folks are going to have frequent pneumonias, so you want to be able to identify which organisms, and if they have flare-ups that are occurring. Definite bronchial hygiene, positioning of them. They're frequent candidates for bronchoscopy because of their inability to adequately expectorate. Hyperinflation techniques can help. CPAP is there, but again, that'd be more of in the acute state than in a chronic state. They are good candidates for non-invasive ventilation because, and usually during the day they're not so much of a problem, but at night they hypoventilate and get into trouble. So a lot of these folks will just be on nocturnal ventilation. There was actually the gal who used to run the HPS, her sister had this, and she was in an iron lung at night. I think to this day. So. Yeah, that's part of it. That's part of it. As they're lying flat, they end up having more a bigger deficit, yeah, and the more inability to adequately ventilate. And I think we'll leave it there. Yes, question.